All right, let's jump right in. In terms of HPV, we all know it's a big topic. Certainly in lay press, it's almost certainly something you've had discussions with your surgeons about. So it's certainly out there, something we want to get a good handle on, and yet the reality, of course, is there is a lot of data on head and neck HPV and its significance, and it's kind of a mess, if I'm being honest. If you look back, it goes back to the 80s. It's often contradictory. They're using different methods of detection, and it's kind of a mess. So what to do? Well, this is where the CAP decided a few years back, let's try to create some guidelines and give people a little direction on how to do HPV testing in head and neck cancers. So this was a success, I think. It was a few years back. We published in 2018, and we are now in the beginning stages of a second go-round. So the point of it was to take all of that data that's out there, which there's, as I said, a ton of it, kind of distill it down to some recommendations that people can actually use and are somewhat practical. So basically, you don't have to go through all that old data like we did. So yeah, you've probably seen these by now. Like I said, it's been a few years. These have been published. The CAP HPV testing guidelines kind of looks like a lot when you first look at it, but there's only really a handful of really high yield ones that you're going to use every day, and we're going to go over those in this talk today. As I mentioned, this is published. It's free, obviously, to access these CAP guidelines. So recommend you do that. You don't have to read the whole paper, but the summary is pretty good. So in terms of background, this is stuff you probably know, but for decades, the rates of head and neck cancer tracked perfectly with rates of smoking, which obviously is very intuitive. It makes sense. And then something very odd started to happen around the 80s, and it really diverged in the 90s and 2000s, where the rates of head and neck cancer began to rise again, despite the fact that smoking rates continued to fall. It was a bit of a conundrum for a while there. What's causing this? Of course, we know now what is causing this is high-risk HPV. And that's illustrated nicely in this graph, just showing you what we all are kind of aware of, which is the rates of head and neck cancer caused by HPV are skyrocketing and continue to do so into epidemic-type levels, whereas HPV-negative head and neck cancer does continue to fall. So quick break for an audience question. What percentage of oropharyngeal carcinomas are HPV related? I should put a slight clarification there in the West, right? So it is somewhat geographically different. If you're in India or in Asia, these tend to be lower, but in the West, in the US and Western Europe, it is 80 to 90%. Very, very high these days. So yeah, as we know, high-risk HPV is not uniformly distributed in the head and neck region. It's very, very concentrated to the oropharynx, where yes, 80 to 90% of oropharyngeal carcinomas now are HPV related. And it's really even more precise than that. It's the tonsillar crypt. That is the hot spot. That is the location where all the action is happening. This crypt epithelium, this specialized so-called reticulated lymphoepithelium, is, we now know, particularly susceptible to infection by HPV and then subsequent carcinogenesis.